Welcome, everyone. Thank you for joining our presentation today, Billing for Article 29I Facilities, Medicaid Managed Care, Core Limited Health-Related Services. I'm Yvette Kelly with the Managed Care Technical Assistance Center, and I am joined by my colleague, Boris Vilgorin. Also joining us today is Sonia Rolson from the State Department of Health and Mimi Weber from the New York State Office of Children and Family Services. So before we get started, just a few points to note. This presentation is not the official document, and for full details, we ask that you please refer to the provider and billing manuals. Also, we've made every effort to ensure information and timelines are current as of today's presentation. Here is a quick view of our agenda for today. We will begin the presentation with a brief overview, which will be provided by our state partners. We'll then move on to discuss service and rates, claim requirements, coding, billing, and covered populations before leaving you with some resources. And with that, I'm going to pass it over to our state partners to get us started.
Hi, everybody. This is Mimi Weber from the New York State Office of Children and Family Services. And let me start by thanking everybody for taking the time to review this really important webinar. We want to acknowledge that this is new, and with everything new, it takes some time to figure out. And so, again, we appreciate you taking the time to figure this out. We want to acknowledge that as complicated as this may seem out front, we do firmly believe that this will result in better health care services for some of New York State's most vulnerable children. So with that, it's really important that we get this right. I want to thank our friends and colleagues at the Department of Health. I also want to thank our friends and colleagues at MCTAC for making today's presentation possible. There are lots of resources available to help you through this transition to make sure that you can, bill properly for these important healthcare services that you're providing to kids. So with that, I'll turn it over to Tanya at DOH, and once again, thanks everybody for taking the time to listen.
Good morning. Thank you, Mimi. I would just echo exactly what you said. So welcome, and thank you for participating, and we'll get the webinar started.
Great. Thank you, Tanya and Mimi, for that overview. And that brings us to the purpose of today's presentation. So we will review the billing requirements for services provided by 29I licensed health facilities, which are administered by the New York State Department of Health and Office of Children and Family Services. As a reminder, the 29I facility billing manual has been released and is available for review. But when reviewing, we just please note that this manual provides billing guidance only and does not supersede regulatory requirements or procedures. So there are two categories of services that can be provided by Article 29I health facilities. These include core limited health-related services, which are mandatory, and other limited health-related services, which are optional. Today's presentation will focus on billing Medicaid managed care plans for these mandatory or core limited health-related services. In order for voluntary foster care agencies to be prepared to deliver and bill for these services, there are several fundamental requirements that need to be met. First and foremost, voluntary foster care agencies must be licensed. Agencies who are not licensed are not authorized to provide these services. All VFCAs that are licensed as 29I health facilities will receive a New York State DOH-issued license indicating authorization to bill for these services. Additionally, for services to qualify for Medicaid reimbursement, the youth health or behavioral health record, treatment plan, service plan, and or plan of care must reflect that the services provided meet the following criteria: that services were medically necessary and appropriate, and that the services were rendered by qualified practitioners within their scope of practice as defined in relevant law. As the provision of these services require that medical necessity be established, there are a few things to be mindful of. So medical necessity must be determined by a licensed practitioner of the healing arts and must include how core limited health-related services address any of the following: the need to deliver preventive supports through an array of clinical activities, including the exchange of information with other Medicaid services, to reduce the severity of a health issue that has been identified as the reason for admission, and or to provide targeted treatment directly related to the youth's ability to function successfully at home, school, and in the community. For all eligible providers who plan to bill Medicaid, they are required to be enrolled as a Medicaid provider in order to receive reimbursement for delivering a Medicaid service. 29I health facilities must be enrolled with a category of service code 0121 to bill for core limited health-related services and a category of service code 0268 to bill for other limited health-related services. For more information on how to become a Medicaid provider, please refer to the eMedNI website as listed here. So 29I health facilities are highly encouraged to contract with all managed care plans that are located in the service area in which core limited health-related services will be delivered to youth. Plans are required to offer contracts to all 29I health facilities who are licensed and operating within the plan's service area. The plan's service area consists of the county or counties that are listed in the plan's current Medicaid managed care contract with the state. Providers and plans may also choose to enter into a single case agreement if needed to facilitate payment to a 29I health facility who has not yet contracted with a plan. And you can find more information regarding the requirements and standards at the link noted. So next we will just spend some time detailing the services and rates associated with core limited health-related services. And so again, all licensed Article 29I health facilities are required to provide or make available through a contract arrangement or all core limited health-related services. And as discussed, medical necessity must be documented in accordance with the 29I health facilities licensing guidelines. So what services make up the core limited health-related services? So there are a total of 5 core limited health-related services, and they include the following. Skill building, which is inclusive of counseling and interventions such as individual and family counseling. Nursing services, which may include routine screening for a number of health and behavioral health disorders. Medicaid treatment planning and discharge planning, which supports the coordination of services. Clinical consultation and supervision, which may include working directly with the treatment team providers and the Medicaid managed care liaison administrator who will coordinate with the plan's foster care liaison. As I've only provided examples, please refer to the 29I health facilities licensing guidelines for more information regarding the description and allowable services under this category. In terms of billing, core limited health-related services are reimbursed on a per-child, per-day basis and billed to the Medicaid managed care plan if a youth is enrolled. For those youth who are not enrolled in a plan, these services are billed fee-for-service. Managed care plans will serve as the pass-through billing entity during this 4-year transition period, paying providers at the fee-for-service rates. At the end of the transition period, the state plans to reassess the progress of implementation and determine if transitional requirements should be extended. The rate for core limited health-related services is the Medicaid per diem rate, and this is the rate for which Article 29I providers will be reimbursed. This rate is inclusive of routine transportation. The rates for these services are associated with the 29I facility type, which is indicated on the agency's license. And for more details regarding the rates for these services, again, please click on the link that's been provided here. Next, we'll spend a few minutes just talking about the cost allocation of these services. So both core and other limited health-related services must be provided and billed for separately. 29I health facilities may not separately bill for activities performed by a professional when 100% of the full-time equivalent is funded within the Medicaid per diem rate for the provision of core limited health-related services. Facilities may allocate a percentage of an individual practitioner's FTE to core and other limited health-related services based on actual time spent providing those services. However, time spent by practitioners providing core limited health-related services must be allocated to and billed under the Medicaid per diem. Facilities must make sure to appropriately allocate the costs associated with each type of service in the annual cost report submitted to the state. In circumstances where a child is receiving services from an Article 29 health facility and a community provider, such as an outpatient mental health clinic, concurrent billing may be acceptable. It is only acceptable when a clinical need is identified that is distinctly different and non-duplicative to those needs being addressed by the Article 29I health facility, and it's determined that it's medically necessary to provide those services concurrently. So, for example, consider a case in which the Article 29I therapist is providing individual therapy to the child and identifies the need for family therapy. The therapist determines that it's necessary and beneficial for family therapy to be provided in the outpatient mental health setting. In this example, billing for both the individual and family therapy would be appropriate and allowable. In this case, both the Article 29I therapist and the outpatient mental health therapist would have separate treatment plans addressing different goals and objectives in therapy, thus substantiating distinct clinical needs and interventions for each service. In accordance with best practice, the Article 29I therapist and outpatient mental health therapist would be expected to collaborate with consent from the child and family to ensure alignment in their treatment interventions. For those step-down agencies, beginning July 1st, 2021 through July 1st, 2024, transitional rates for core limited health-related services will be updated yearly. On July 1st, 2024, all 29I health facilities will be reimbursed the standard rate schedule based on facility type. For those facilities receiving a transitional rate for these services, rates will be specific to the facility type that is transitioning with a unique agency-based rate. Rates for core limited health-related services differ based on both the level of care and the facility type the 29I health facility is operating, with one rate assigned to each of the 13 facility types. Since a 29I health facility may operate more than one facility type and one or more levels of care, it may be necessary for a facility to bill several different core limited health-related service rates. Rates billed must correspond to the rate for the facility type in which the child or youth is residing. There are some billing limits that providers must be aware of when billing for these services. Some of these limits include that only one core limited health-related service rate per day for each individual youth can be billed, that services are billed daily and can be submitted within a range of multiple dates of service on one claim, that the Medicaid per diem rate is paid for the duration of the child's stay in the 29I health facility, and the Medicaid per diem rate is not reimbursable after the youth's 21st birthday. The next few slides details the different levels of care and facility types. And just a reminder, there are, again, 4 distinct levels of care with 13 different facility types. It's also important to note that core limited health-related services are not subject to regional reimbursement differences, as the Medicaid per diem rate was calculated as a statewide Medicaid rate. While we will not go over the next few slides in great detail, these slides do show the associated rate and procedure codes for each level of care and facility type. They also provide the unit of measure as well as the soft limit associated with each level. And so, again, not going to go over these in detail, but you can refer to them in the Article 29 Facility Billing Manual for more information. And with that, I'm going to pass it over to my colleague Boris, who will walk us through the next part of the presentation.
Excellent. Thank you, Yvette. And as we move on from the rates and billing information, what we wanted to cover is the claim requirements and really dive into a little bit into some of the components of the claim itself. So again, when we discuss the claim submission to the Medicaid managed care plans, providers really should check on the individual enrollment in Medicaid and be very mindful on their status. So just to be mindful, so please do not submit claims if an individual is not enrolled in Medicaid, of course, or is not eligible for the services provided, or might be not in the particular plan you're submitting this claim for. So again, if the Medicaid managed care plan for which the individual is not a member. And again, the prior authorization is not required for core limited health services and or mandated assessments. So keep in mind, as always, in regards to individuals' eligibility with Medicaid and Medicaid managed care. Some of the additional billing requirements, again, providers must adhere to the billing and coding manual requirements, as well as the clean claim rules as outlined in the billing tool found here. Again, you can see the link provided. So when you get the slides, please feel free to click on the link. The Medicaid managed care shall support both paper and electronic submission of claims for all claim types. And also, Medicaid managed care shall offer providers an electronic payment option, including a web-based claim submission system. All Medicaid managed care plans will require claims to be submitted with CPT code and modifiers. As you heard, Yvette provide some of that information. Again, and of course, if modifiers, if there are applicable. And in addition, you would need to include a state-assigned rate code. Again, please refer to the manual appendix for a complete listing of CPT codes and associated modifiers. As we continue some of the billing requirements, as usual with claims, an NPI number, a National Provider Identifier, associated with the 29I health facility is required to be on the claim. For use of 837I and UB04 claims, the 29I health facility will enter the rate code in the header of the claim as a value code. But please make sure that in the value code field, you first type in 24, which is then followed by the appropriate 4-digit rate code. All Medicaid managed care plans will be provided with a complete list of all existing 29I health facility and their associated rate codes they are authorized to bill under, as well as the rate amounts by each MMIS provider ID number, locator, and or NPI, and plus ZIP-4 billing requirements, depending on type of the facility. Again, looking at ongoing requirements for billing, just to highlight, 837I is an electronic version of the claim, and UB04 is the paper form, which will be utilized to bill for core limited health-related services. Each claim that you submit will require at a minimum the following: the primary diagnosis code, and you will be using the ICD-10 version for that definition. You also will need to include, as mentioned, the rate codes, the procedure codes, and modifiers. We also will need to include units of service, patient reason for visit code, and revenue codes, which are 0529 and 0519 for per diem core codes. Again, these are just the required elements. There might be additional elements for the claim that you would need to complete. And please always refer to the appendix, as was mentioned, for more information. Now let's turn our attention to some of the coding, in particular requirements. So core health-related services coding. Again, the procedure modifiers combination must be adhered to. It's really important that you pay attention to those combinations between the CPT codes and the modifiers. Both you as a provider and Medicaid managed care plan need to assure appropriate rate payments, and they are determined by those combination. The combinations indicate to the Medicaid managed care plan that the claim is for the services provided to the children in the care of 29I health facility. If you do need to include two modifiers, and if they are needed, both modifiers must be present and do not require a provider to indicate them in the exact same order for every claim for payment to be made. Again, as mentioned earlier, in regards to the revenue codes, please make sure to utilize revenue codes 0529 and 0519. Some additional billing requirements. When we're talking about the day one billing, and again, that which would be July 1st of 2021, we want to make sure that Medicaid billing rates will be loaded and assured into the provider profiles, and that when you are billing, being very careful around that transition time, that the dates of service are appropriately identified, because the dates of service will determine how to bill. So, for example, if you're billing for a June 30th date of service, we'll be billing using the old methodology, even if you're submitting the claim in July. So again, important to make sure during that transition from June to July and into Medicaid managed care that you follow these rules accordingly. And as always, can't emphasize enough, please, please, please do claim testing as much as possible, even in instances where you are familiar and know how to bill Medicaid managed care. This is new in regards to billing, and it's always important to do claim testing. It provides both information about your own system and ability to submit these claims, but also allows for Medicaid managed care plans to test their systems specific to your organization. So can't emphasize enough for folks to really take the opportunity and time to do claim testing as much as possible. And with that, I'll turn this over to Tanya, who will take us through the last section of this presentation.
Thank you, Boris. All right, so we're going to just review some absence categories. So when the child or youth is absent from the 29I health facility, there are times when you can charge the per diem, and there are instances where you cannot. So we will start with the instances that you can. So absence category is when it is permissible to claim the Medicaid per diem. So a child discharge, non-secure legal detention, and absent without consent. It says we rate for you can bill for consecutive days 1 through 7 per absence. So, on the 8th day, you would not be able to bill. You go to the next slide. So we also have additional instances that you can bill. It is permissible to claim, and that is weekend visits. So a kid goes on a weekend visit somewhere, school and religious holidays, vacation days, including stays at camp, and that will be up to 21 days per calendar year. So that could be done in, 21 straight days, or it could be done in, in a couple different weeks, but on the 22nd day it would not be paid. Visits to potential foster or adoptive parents, up to 7 consecutive days per visit. Organized school trips. Foster care youth attends and is a resident of an in-state or out-of-state college, university, technical vocational training setting, but the foster care placement setting is within New York State, so you would be able to claim the per diem then as well. And respite care and services, non-institutional, of course, or non-institutional and institutional respite care. Next slide. And when you cannot claim the per diem, those categories are inpatient hospital stays, other residential facility settings when the entity is reimbursed via Medicaid as well. If the 29 health facility has advised the fiscally responsible local Department of Social Services that they will not accept the return of the absent youth in the foster care to their agency, then none of the absent days, even if they would otherwise fall into a permissible category, will not be reimbursable. The 29I health facility must discharge the youth. Next slide. So now we're going to look at some of the populations. So what are some of the circumstances that the children or youth are in the 29I facilities, and then, how the core per diem would be paid. So most New York State children and youth in foster care are Medicaid eligible simply by the virtue of being in their foster care status. This includes children or youth who are United States citizens or have satisfactory immigration status. 29I health facilities may provide core limited health-related services and other health-related services following population. So we're going to look at the core here because that's what this webinar is about. So again, just a reminder that the transition is a 4-year transition period. And here's a few categories where the per diem would be paid. So foster care placement in the care of a 29 health facility. So managed care pays the per diem for those enrolled, as well as kinship certified placement, same circumstance, the plan would pay for those who are enrolled. Kinship placement not certified, there would be no payment. It would not apply here. And then the CSE is paid just like it is today. So there is a calculation. Core health services are included in the CSE daily rate, and the calculation is there. So 8D babies, the plan pays per diem for the days the child is placed in the facility for the reimbursement rate at the program level where the child is placed. So it's just like any other child or youth in placement. Out of placement, non-4E, they're excluded from plan enrollment, so there would be no per diem paid. Out-of-state placement 4E, to be enrolled in Medicaid in the state which the child is living in. And then former foster care adults older than 21 that are still in the care of a 29 health facility claims would not be paid on those. Children placed in a setting that provides comprehensive care, such as inpatient setting, nursing facility, or an OPWD facility, the per diem is not billable while the child is in one of those settings. Children under the custody of the juvenile justice system, it doesn't apply. And then pre-dispositional placed youth, the core health services would be paid by the county, the LDSS. Denial management. Providers may appeal claims that have been denied, and then we just give you a reference here to the transition of children placed in foster care. This is the policy paper, and there is a link provided. Please look at that policy paper for additional details. There's also, we pulled the complaint telephone number and the email for you to easily access if you do have issues with claiming or any kind of issues with the managed care plans. These are the 2 places that you can funnel your complaints. And additionally, if you have just general questions, as usual, you could just use the bh.transition@health.newyork.gov, and those questions will be routed according to what kind of question they are. Additional resources, several links to the guidelines, the billing guidance, the policy guidance, and additional Medicaid timely filing guidance. And the additional resources again. And so that concludes our webinar. And if you, again, have any questions, please email the bh.transition@health.newyork.gov. And thank you for your time.